Hello, everyone. Welcome to another IMG initiative episode that we have on Saturday. Today we have a really special guest from UPMC Internal Medicine Residence, and we are super happy to have them all with us. And I want to ask them to introduce themselves. Can you introduce Valentina?
Yeah, of course. Hi, guys. It's really nice to be here. Nice to meet you virtually. I'm Valentina Jaramillo. I'm one of the UPMC internal medicine chief residents this year. I'm actually from Medellin, Colombia. I grew up there, did medical school there, and I moved to the States in 2018. Initially, kind of like did a little bit of research in Arizona where my husband was at the time, and then I moved to Pittsburgh for residency. And I loved it so much that I stay as chief. I really am really passionate about our program. I'm part of, I don't know if you've heard from Pittsburgh, but I'm part of the international scholar track. So that's kind of like the way, the only way kind of that you do residency as an IMG in Pittsburgh. So I can tell a little bit more about our program later on. And I'm here today with one of our wonderful PGY2s. This is Dr. Chowdhury, and she is one of our global health track residents as well. She's the one that's going to present the case. I'm just going to let her introduce herself a little bit and tell us who she is too. Irada, go ahead.
Hey everyone, my name is Irada Chowdhury. As Val said, I'm a PGY2 here at Pittsburgh. I'm originally from Michigan, and I attended University of Michigan for medical school. One of the reasons I came to Pittsburgh was because of the global health track here. It's a really unique track where you have a lot of opportunity to travel while in residency and learn clinical medicine in different parts of the world as well as the country, and focus on underserved medicine as well. And since I've been in Pittsburgh, I have become a Steelers fan, which has been a shock as someone who has never watched professional football before. And I'm really happy to be here because I really like my colleagues and the people I work with and our patients. So looking forward to having a chance to share one of our experiences with you all.
Amazing. Thank you so much for being with us. And we always like to ask a little something for our guests, like what you guys like to do outside of medicine to have fun.
I think I can go first. I'm a super into yoga. So much to the point that when I was doing this couple of research years, I was doing every day. So I decided to actually train. So I'm now a certified yoga teacher. So I love to do yoga as much as I can. During residency, it was tough. And also the pandemic hit and it was kind of complicated, but that's one of my favorite hobbies. I also like to play tennis a lot. And then I will say that the other thing that I do a lot is travel, unfortunately, because I still am on a long distance relationship with my husband. So I'm currently actually in Arizona right now. So that's it.
I like to run, which is really nice in Pittsburgh. We have a lot of rivers, so I like running along the rivers and get a beautiful view. Other things are cooking, and I also have a little bit of an online shopping habit. So those are my hobbies outside of medicine.
I love it. Thank you so much for sharing. I think, Noah, can you share the screen before we start? I think we can start, Irada.
So, chief concern, 85-year-old female presents with a chief concern of bilateral lower extremity swelling.
Okay, wow, yeah, thank you so much for this introduction. I think this is one that we're familiar with and such a great way to start. So I guess, Kiara and Francisco, I don't think you guys need me at all. So I'll just kind of pass it back and forth between you all and chime in whenever I feel like I can contribute, which probably won't be very much. So, but Kiara, why don't you get us started here with what are you thinking right now?
Sure. I don't know if I should start. Thank you so much. I don't know if I should start with the age of the chief concern, but I will start with the chief concern. So when I hear about lower extremity swelling or edema, I'm trying to translate it to edema. So for me, there are like two buckets: cardiovascular or non-cardiovascular. Of course, that common things of lower extremity edema are cardiovascular, renal, and liver disease. So with cardiovascular, we have many problems, and I'm going to mention those that could be related to this female age. So with this, one of my concerns are congestive heart failure, even if the patient had already heart failure, or this is a heart failure exacerbation. Also, I have to think about some concerns about the heart itself. For example, tricuspid regurgitation, stenosis, mitral regurgitation, etc. And also, I always want to consider within the cardiac buckets also if there is some core pulmonary. I'm not so sure about this patient may have or may have not a core pulmonary. And venous insufficiency, of course, which is one of the most common concerns and can present with bilateral lower extremity edema, of course. And of course, venous obstruction also in my differential. So with the non-cardiovascular problems, the liver is on top of my head, so I will be thinking about cirrhosis in this case, or any kind of disease that can decrease the albumin levels. For example, nephrotic syndrome, malnutrition, especially in elderly patients. Malnutrition would be a common cause of low albumin. And also common things, but I'm not so sure that because this is bilateral lower extremity edema, but another common thing is cellulitis, which commonly presents with one leg predominance. And I think that's all what I'm thinking. Also, I have to consider drugs, change in medication, polypharmacy in this case, mixed edema. Many things to consider so far, but those will be my top concerns. What do you
Awesome,
think,
amazing.
Francisco?
Yeah, Francisco, anything else to add that you were thinking about? I think you're muted, unfortunately.
Oh,
It might be your microphone then.
Try again.
okay, sorry.
We can hear now.
You hear me now?
Yes.
Yes, perfect. Okay,
Yes.
I'm sorry, guys. So what I was saying is that I have basically three questions that I think that are going to be addressed in the HPI. So one of them, I think that Chiara already touched upon, which is the fact that it's very important that it's bilateral and not unilateral. So we start to think about systemic causes. But of course, we cannot exclude some bilateral infection, even if it's probably very rare. Then I want to understand if it's chronic or acute. That is also something that is very important. And I also want to know the extension of this edema. So does the edema go to the groin? Is it a generalized edema with anasarca? So those are the three questions that I would like to get answered.
Yeah, no, guys, beautiful introduction and a great approach. And I think both of you really highlighted sort of the three main bucket organ systems that we think about with bilateral or extremity edema. You also were kind of playing into the age and the time course and how that's going to kind of frame our differential diagnosis or prioritize certain things versus others. And so I really can't add much to that. All I can say is that if we take an 85-year-old and, as you guys nicely outlined, think about what the potential causes of lower extremity edema are. I think the further you get in life, the more likely that you are to have multiple explanations for why someone is presenting with a condition versus one. So, for example, I have a 92-year-old grandmother, and she has the worst bilateral lower extremity edema I've seen in some time, all from venous stasis, right? But eventually, we might discover that she has heart failure. And so it's sometimes helpful to know, like, okay, she had some amount of edema, and now it's worse. And so is that a reflection of worsening of the primary problem, or is that a reflection of a new process on top of a pre-existing problem? And so I think in an 85-year-old, that's something that we're really going to have to keep in mind, maybe more so than someone that's 20 years old. But that's really only the sort of little pearl I can add to you guys' already awesome discussion. So I think we're ready for the next aliquot. Thank you so much.
To answer some of the questions that were raised, she has not previously had lower extremity swelling, but the swelling she has onset about 2 to 3 weeks ago, and it's been progressive since that time. She's otherwise been asymptomatic. She denies any pain in her lower extremities, and one of the main reasons she came to the hospital is because she originally presented to her PCP, who was concerned about the extent and progression of her lower extremity swelling. At this time, her lower extremity swelling is pitting in nature.
Can you give us a little bit more information, like the past medical history, medication, please?
Sure. So in terms of her past medical history, she's had a hiatal hernia, hypertension, hyperlipidemia, arthritis of her spine and hips. She had, in terms of her medications, she's on Tylenol, aspirin, calcium, vitamin D supplement, lisinopril, multivitamin, Protonix, and simvastatin. In terms of her family history, her father, he was deceased in his 70s from a MI, mother deceased in her 80s from a brain tumor, and then sister deceased at age 27 from breast cancer. In terms of her social history, she is married, lives at home with her husband, no tobacco, alcohol, or drug use. She has no known drug allergies. And in terms of her ROS, she denies constitutional symptoms, including unintentional weight changes. She also denies shortness of breath, orthopnea, or PND as well. No changes in her bowel movements, no nausea, vomiting, or diarrhea. No changes in her urine that she's noticed, including frothy urine.
All right, so should I go, Austin? Yeah, so this is very interesting because even though I got a lot of answers to my questions, there are a lot of unknowns. So it's interesting that she isn't doing any type of medication that could probably be the cause of this edema, which is kind of subacute, acute in nature. It's not chronic and has been progressing. So something has been happening. It's pitting and there is no pain. So I would probably stay away from a lymphatic cause and think that there's a problem in her venous system. So this is bilateral. So I'm wondering, given her age, if she may have any sort of big clot that affected both iliac veins from probably an unknown malignancy. She doesn't have constitutional symptoms though. In terms of cardiac, I think she would be very dyspneic, and Chiara started on probably considering cardiac causes, and she doesn't report any breathlessness, shortness of breath, and then she doesn't have also, she does have hypertension though. But yeah, I would like to hear your thoughts, Chiara. What do you think about the current problem representation?
Yeah, so I agree with you. I don't know if it's a relief, but I'm glad it's not that acute, because if it's acute, I will be thinking about some DVT or I don't know, some acute renal process, etc. But when I'm think 2 to 3 weeks, I'm thinking about chronic causes. It is top of mind, still cardiac causes. Maybe this is a patient that has been with some ongoing heart failure without symptoms, and she's now developing lower extremity edema because her past medical history and her family history is suggest for some cardiac causes for her too. But she has no specific symptoms for a heart failure exacerbation. So I'm right with you that that doesn't help much. So whenever I have an elderly patient, I always have to consider a number of things. First, how many medications she is on, to check if she is on polypharmacy. Then if she is compliant to her medication, which is very important, or if there is any changes, because acute changes in medication can develop any sort of problem like this. So also this is with the cardiac causes probably, but also she's an elderly female, so of course a malignancy is also a differential, and we have to consider maybe if there was, as you mentioned, if maybe there is a weight loss, fevers, or any radiation that we don't know that she had previously. So that's for me. And my problem representation would be elderly female with past medical history of hypertension, hyperlipidemia, and arthritis on polypharmacy, who develops chronic progressive bilateral lower extremity edema. That will be my problem representation.
Good. I mean, oh my gosh, you guys already had a really nice framework for everything. I think if we, I'll pose a question to you guys, and I think you guys already highlighted on this, but I just want to highlight the point a little bit more. If you step back and said at the beginning, okay, what are the 3 most common buckets that we think about when someone that's presenting with bilateral lower extremity edema? You said the heart, the liver, and the kidneys, right? And which is a perfect answer. So here you guys made an argument for why you don't think the heart is at play. So based off the history that we have, what do you think, which organ system really comes to the forefront, the liver or the kidneys?
The kidneys.
Okay, good. Yeah, why?
I think she doesn't, because they can be not so symptomatic, sort of. So she can have probably some condition that is inducing an hypercoagulable state from like a glomerulonephritis or something, and so we will need to probably assess if she is fluid overloaded or not to make a stronger argument on that.
Yeah, so I think what you're recognizing is saying, hey, at least from the information we have right now, there doesn't seem to be more of any central picture of volume overload, right? It seems to be that we're isolated to the periphery, but because that is relatively subjective by history, we have to operate under the assumption that, you know, we're going to get more information. We're going to do a physical exam to really objectify whether or not there is the presence of central overload or not. But based off the history that we have, which is excellent, we can say, hey, the likelihood of this being a heart problem is lower. She certainly has risk factors, but we don't have any other feature to suggest that. And so because of that, and we really have isolated edema with no other localizing signs, this is going to prioritize the kidney over the other two large organ systems, right? We still have to be open to the other possibilities, as Chiara mentioned appropriately, like medications can cause any side effect to any patient at any time. There are medications that she's on that can cause edema. Protonics, for example, can rarely cause lower extremity edema. And it was a patient that taught me that. You know, again, the time course of like when are these started and everything, and it's extremely unlikely because it's a very, very rare side effect. So I agree that sort of first pass look at the medications, you know, it doesn't seem like any of them are culprits. Like we don't see amlodipine or gabapentin or any of those on there. But I think we have to be open to the hypothesis, and then we also have to be open to the fact that, you know, we always have to take the history in the context of the functional status of the patient, right? I think we have a little bit of information about her, but she might not have dyspnea exertion if her baseline functional capacity is that because of her arthritis, she's in a wheelchair and she doesn't really move around, right? So we have to know what the functional status of the patient is to really make sure that we're interpreting the history in the right context. And so history is just your first pass. And then once you get the functional status and the physical exam, which gives you a sense of what the patient's functional status is, then we can really understand if we're solving the right problem or not. But I think so far we have a lot of great information. You guys have a really nice approach. And so it'll be interesting to see the physical exam and how this can help us make progress on what's going on here.
On exam for her vitals, she's afebrile to 36.6. Her blood pressure is 125/71. Respiratory rate is 18. She is sitting at 96% on room air. Her BMI is 25.6. Generally, she is alert and oriented, not in acute distress. She appears her stated age. For hint, she has no scleral icterus, normal conjunctiva, moist mucous membranes. And she has palpable lymph nodes in her left cervical region and right axilla. On cardiovascular, she has normal rate, regular rhythm, normal peripheral perfusion, and 2+ bilateral pitting edema to the knees. Her neck veins are flat. On respiratory, her lungs are clear to auscultation. For GI, soft, non-tender, normal bowel sounds. She has a large hiatal hernia. And for neuro, as previously mentioned, she's alert and oriented, ×4. Her cranial nerves are intact. She's moving all her extremities spontaneously. And apologize, I didn't see the bottom extremities and skin, but her skin, there's no obvious rashes or lesions.
All right, Chiara, what do you think? Do you see aliquot here?
Yes, this case is going so great so far. Well, so I'm kind of now reassured that this may not be a cardiovascular cause. But now with this, first, the vitals are good for me. She's hypertensive. Her blood pressure is normal, so that is reassuring for me. Her BMI is high because she's in the borderline for obesity, overweight, sorry. So I don't know what to do with that so far, but now with this cervical lymph nodes that that are mentioned in the physical exam, I'm concerned about 3 things, especially infections, malignancy, and autoimmune diseases. my top differential would be infections and malignancy. Autoimmune would be too, because she has arthritis of the spine and hips. I don't know, maybe she has an undiagnosed rheumatoid arthritis or any sort of autoimmune disease. But if I have to think about an infectious cause, I will be considering any kind of infection around the face or the neck, which can drain into the cervical lymph nodes. That would be one of my concerns. The second, with malignancy, any kind of lymphoma or metastatic cancer that can drain in the cervical lymph nodes would also be a big concern to me. And of course, the autoimmune causes. I don't know what else to do. What do you think, Francisco?
No, great introduction, Chiara. So I think that bearing in mind what we discussed, we can probably say that there's no fluid overload, so probably cardiac causes. We can exclude that. So now I think we need to go after those lymph nodes and probably assess if the patient has more lymph nodes in the mediastinum, in the abdomen, and if they are either causing some kind of obstruction, or if it is indeed a malignancy-induced glomerulonephritis. So what do you think, Austin?
Yeah, I mean, I think I really love what you guys did. I think you recognize that here we sort of have a pivot point, and we say, hey, now we have lymphadenopathy, and this is really the problem that we have to solve. And then we're going to have two overlapping Venn diagrams. We're going to have lymphadenopathy, and we're going to have lower extremity edema, and we have to figure out where those overlap to be able to solve the problem, right? Because the patients, sometimes whenever a patient comes to the hospital, they say, oh, I have chest pain, and then they get to the ER and they have this terrible rash, and so they get admitted for this rash, and then we forgot that they had chest pain in the first place, and they have to go out and figure out why they have chest pain. So we really have to make sure that we keep in mind what her primary concern was and overlap that with what's happening. We have to be open to the possibility that these are unrelated, but I think given the time course and how the patient presented, most likely these are going to be related. And so how can I overlay these? I think what you guys did really well is you said, hey, I'm taking lymphadenopathy and I'm translating that to inflammation. And the way we approach inflammation is, infection, malignancy, autoimmune, drugs, and endocrinopathy. And I think you guys prioritized which ones to go through pretty well. I think what you also did is that you said, I'm taking cervical and axillary lymphadenopathy and saying, this could just be the surface of what the lymphadenopathy could be, right? Our exam is okay for detecting lymphadenopathy, but we can't feel what's inside the mediastinum. We can't feel what's inside the abdomen unless they're really, really bulky, right? So this could just be a surface, sort of scratching the surface or the tip of the iceberg of what lymphadenopathy is. And so that's a problem that we're going to have to solve, or some sort of piece of data we're going to have to get in order to solve the problem correctly. And so I think, we'll be investigating that piece further. Then if we ask ourselves, okay, and you guys came to this a little bit, how can we link lymphadenopathy with lower extremity edema? And you thought, and you're thinking through the potential causes. And I think you guys got to most of them. The ones that I don't have an exact framework for this, but if I just sort of think analogically, I'm translating lymphadenopathy, and I'm just going to say that I think this is probably just scratching the surface, and she probably has more lymphadenopathy that we're going to find. So how can I think about how that could cause lower extremity edema? There could be a pure compression phenomenon. So she has like retroperitoneal lymphadenopathy or something like that. And that can cause compression of the IVC and bilateral lower extremity edema. So that's one way. Another is we think this is a malignancy, for example, either from compression or just from a hypercoagulable state. She could have a thrombus in the IVC, and that could cause bilateral extremity edema, right? Then if we think about, okay, we think she might have an underlying malignancy, for example, she's more predisposed to infections. If she has a glomerular disease, like a nephrotic syndrome, which we could potentially be invoking, but we'll have to get some more information before we can definitively say that. We could say, okay, maybe she has a hypercoagulable state because of that. And then is this I think you also have to ask yourself, is this a paraneoplastic phenomenon? Is this a parainfectious phenomenon? Or is this just related to whatever primary process is going on itself? So I think we also have to ask ourselves here is like, okay, the patient's coming in and basically all she has is bilateral extremity edema. She really has nothing. She didn't mention the lymph nodes to you. They're probably not tender. They're not bothering her. But what, I guess in someone that we're invoking the possibility of having a malignancy, for example, how do we reconcile the fact that she doesn't have any other symptoms except bilateral overstrain? What do you guys think?
I'm sorry, can you repeat? I couldn't understand the last part.
Sure. What do you think? So this patient, we're invoking the possibility of maybe having a malignancy. I think you guys have mentioned that multiple times, and I think that's an important pathway to go down. But how do we sort of reconcile the fact that she doesn't have any other symptoms suggestive of malignancy, right?
Okay. Maybe this is a chronic ongoing process. Maybe she has immunosuppression and cannot develop the common signs of fever and those specific symptoms.
No, I think that's a really good thought, Francisco. And any other thoughts on your end?
Yeah, well, I don't know what's the sensitivity of the symptoms in terms of how frequently are they present when someone has a disease, a malignancy. I understand they can be absent. I don't know in which percentage. But it's a hard question. I would expect that.
Yeah, no, I think you guys are appropriately thinking about it. And this is not an easy question. I don't actually know the answer, to be fair. I think you're exactly right. It probably depends on the type of malignancy that someone has. But I think the main teaching point I'm trying to take away is that patients that are 85 years old, or as we get older, they are in a relatively sort of immunosuppressed state, but they're also less likely to present with the most common features like on history and exam compared to someone that's younger, right? So the classic illness scripts that we learn for cancer, for heart disease, for all those things don't really apply to someone that's 85 years old. So you always need to be humble when approaching someone, any patient for that matter, but in someone that's elderly, you always have to be very, very careful that you're exploring all the diagnostic process, like threads, particularly more so than someone else, just because they're much more likely to present atypically than many other subsets of patients. So that's really the main teaching point. So I think we're going to be learning a lot from the labs and imaging. So I'm really excited to hear more.
For CBC, here is 13.4 for her white count, 10.8 for hemoglobin, and platelets of 614. 8 months ago, her outpatient labs showed a white count of 7.5, a hemoglobin of 12.3, and platelets 271. Her sodium is 130, potassium 4.4, chloride is 96, her BUN is 16, her creatinine is 0.9, her glucose is 96. Calcium is 8.8. We don't have, her MAG is 2.2. AST is 29, ALT 12, ALK-Phos 153, albumin 3.2. Her total protein is 5.8. And we did not get a troponin for her. And GFR was essentially normal. And I can provide other labs too at this time, or hold off.
Do you have a differential on the white count?
No, it was normal.
Okay, thank you. Yeah, I think a little bit more information would be helpful.
Her BNP was 29. TSH was 1.2. She had an LDH of 203. Her B12 and folate were normal. And her irons, in terms of her iron studies, her iron was 13. Her TIBC was 252. Her percent SAT was 5%. And her ferritin was 206. We also obtained a CA19. Which was a CA19, which was 24.4 within normal limits. Her CEA was 1.8, which was within normal limits. And then her CA 125 was 10,786, our upper limit of normal being 35. Her UA was grossly normal, no protein.
Very, very interesting. So we start off thinking about heart, kidney, and liver, and we end up with probably them not having any type of disease. So it was very helpful to have the 8-month CBC. So I'm considering it's kind of a weak point, but if that's probably on the lines of a myeloproliferative disease. Not sure if this can just be the platelet increase in secondary to a malignancy. It can be that too. So she has a CA 125. I think a lot of cancers can give this value. Not sure if it's gastric and ovarian cancer. So I would probably still think that not forgetting about the pitting edema, some sort of compression that is the cause of the secondary, either to a malignancy or a prothrombotic state caused by it. So yeah, I think imaging will be very important, but I think we have made some very good progress with the urinalysis normal. And what do you think, Yara?
I am concerned about this patient. So we have anemia, we have thrombocytosis and leukocytosis with normal differential. Just with that, I'm concerned about some proliferative disease, of course. And with the chemistry labs, what makes me it's important, what for me, the most important labs that are markedly elevated, LDH is upper limits slightly elevated. What else? The CA 125, that's very high, and that makes me concerned about gynecological malignancies, especially ovarian endometrial cancer. Endometrial cancer is way more common in elderly patients, so that's also important. But also CA 125 can be present just in inflammatory conditions. So with the inflammatory conditions, again, malignancy, non-gynecological malignancy like proliferative diseases are again in my differential. I would like to, I think that how can we make progress? Maybe we have to assess the lymph node, a lymph node biopsy, but by this time, and a CT to assess any other any other place all over the body which may be compromised too.
Well, yeah, I think you guys did a brilliant job interpreting these labs. And I mean, if we didn't know anything about the patient, and we step back and we look at these labs, are any of them, and we ignore the CA-125, are any of them really that helpful in helping us make diagnostic progress? I mean, really not too much, right? I think the only real thread that we can gather from these labs is that the patient is inflamed, right? And I think we have more data, we already were concerned that the patient was inflamed based off of the lymphadenopathy, but now we have really more evidence that the patient is inflamed based off the information that we have. So again, we have sort of this mild leukocytosis. We have this thrombocytosis, which I think Francisco, I think probably correctly identified as reactive thrombocytosis, though we have to be open to the possibility that this could be a primary thrombocytosis, but I agree we have a lot of other data suggesting that's the secondary. And then Robbie has a really nice approach to sort of reactive thrombocytosis, and it sort of comes down to three buckets. So it comes to seronegative autoimmune disease, chronic infections, and that includes like walled-off infections like abscesses, and then solid tumors. And then I like to throw iron deficiency anemia in there, but iron deficiency anemia is like comorbid with a lot of those things, as is anemia and chronic inflammation. So that one's not as helpful. But I think if we overlap those findings with the lymphadenopathy, with the bilateral lower extremity edema, we have some sort of bulky process that involves lymphadenopathy, probably with a sort of center of gravity within the abdomen, given the CA-125. But Chiara expertly pointed out that CA-125 does not equal or elevated CA-125 does not equal ovarian cancer. It is in the United States something that we often do, but there is I think it was Robbie and Reza did a discussion of a case at the Society of Improved Diagnostic Medicine a couple of years ago, and the final answer was very similar to the case like this. And there was elevated one CA-125, and they're like, "Oh, it's ovarian cancer, it's this." And then someone from the room that practiced in India was like, "No, this is tuberculosis. It's always tuberculosis." And the answer was tuberculosis. So in this particular patient doesn't have risk factors for TB or there's other things. But again, I think we like to use these labs to help us localize, but they're really not as specific as we think they are. And then most of these tests are really not that helpful in diagnosis. They're really more helpful in prognostication or response to treatment, or kind of following the course of the patient. So we always have to interpret each test in its context, but with it being wildly abnormal, I think it helps us localize where we are, but I'm not sure it adds too much where we already thought. And then I think as far as next steps, I would say, hey, we need to get a better sense of, what the primary issue is. I think we're not gonna be able to do that without imaging. And then I think, potentially a tissue is the issue for sure. In this scenario, but where we're going to go to get that tissue, I think is going to depend on what we find after we do our imaging. So really excited to learn more.
Okay, to answer one of the big questions regarding her imaging, her CT chest, abdomen, pelvis with contrast showed no acute disease in the chest. Her abdomen showed findings of peritoneal carcinomatosis with omental cakening and soft tissue deposits in the peritoneum. There were also multifocal areas of thickening in the wall of the colon, multiple areas of mild small bowel dilation with gas present in the distal colon, concerning for multiple partial small bowel obstructions due to the peritoneal tumor. She had right-sided hydronephrosis, which is increased from a previous CT, likely secondary to extrinsic compression, though no definite compressing mass is seen. Also, moderate compression of the IVC. Again, no definite compressing mass is seen. She also has moderate ascites. For thoroughness, we also obtained an echo, and that showed preserved function of the LV-RV, no valvular dysfunction.
Wow, fascinating. And how many more kind of aliquots information do you have before you'll reveal the final diagnosis?
Yep. We, as others mentioned, we did obtain an FNA of her left lower quadrant omentum, and it showed adenocarcinoma of Müllerian origin. So that is our last piece of information.
Okay, all right. No, wow, thank you so much for sharing that. And okay, well, I guess that was an amazing case and discussion, and just very tragic for the patient, of course. Coming in with lower extremity edema, which often we sort of, I primarily practice in the outpatient clinic. We see lower extremity edema every day, and usually doesn't turn out to be that someone has metastatic, end stage cancer. So really, really humbling case. And thanks so much for sharing that, and that we can learn from this patient. And I guess Kiara and Francisco, what reflections do you have on the case? And I guess we didn't have a chance to talk about the CT findings, but I guess just give me your general sense of what it was like to discuss and what takeaways you have from the case.
Okay, I can start. So my first takeaway point is that elderly patients present very atypical, and this one of my concerns was that this was a very chronic ongoing process, which I think it was the case. Sadly, we found the cause of the lower extremity edema. There was compression of the IVC, but peritoneal carcinomatosis is not something that develops like very acute. It's something that is very ongoing process. Another thing that is that we also have to consider like a broad image, and I'm always biased by cardiology because I love cardiology, but whenever I hear bilateral lower extremity edema, I always think about cardiology, but there are many possibilities we can have. And I think those would be my takeaway points.
Yeah, this was a great case, and I think that it always reminds us to remain humble, even if we have a very old patient with just something that may seem very normal, pitting edema. Okay, that's multifactorial, and but gladly the doctors pursued it. They didn't give up on the patient. They went after it, and they eventually found a very severe disease. And I think this also reminds us to not anchor on probably things that we think at the start of the case, and we were thinking about kidney cancer, kidney, heart, liver disease, and it turned out to be something way more complex and interesting, unfortunately for the patient, of course. But yeah, thank you so much for the case and for co-discussing.
Yeah, I think those are both beautiful reflections, and I think if I do a brief cognitive autopsy for me, I would say that you guys picked up on nicely. I think there was definitely some subtle hints of that this was a more chronic issue, and I think one way was that sort of like the lack of other symptoms, and the fact that she had this lower extremity edema, and then we found this lymphadenopathy. I think that should have clued me off to say, hey, there's probably something more indolent driving this than what we typically think about. And so I didn't really pick up on that at the time. So I think that's really smart of you guys. I think again, the reflection that this poor woman, I mean, she had multiple small bowel obstructions. She had a hydronephrosis. I mean, she had literally no abdominal symptoms whatsoever, and that is incredibly humbling. If I think about all the patients that come to my clinic with lower extremity edema, how many of them do I stop and say, hey, maybe I should do a lymph node exam on this patient? Some really smart person, I think Errata was like, okay, there's something that doesn't make sense. I need to really think through what the other causes are. I need to do a lymph node exam because I think this person could have a occult malignancy. Given the fact that we don't have any other localizing signs, the patient is 85 years old and is high risk for cancer. I mean, and that's an incredible pickup that certainly I wouldn't have gotten. And so, I mean, I think it's just an amazing reflection of the how great UPMC is, how great the residents are, how great of an institution it is in general, and this is sort of mind blowing. We found that, and I can recall a couple of patients of mine where, to Francisco's point, like whenever you don't have an answer, it's never good enough to just to stop until you get to the end, right? I remember having a patient with bilateral extremity edema, and I was like, oh, this is venous stasis. It wasn't really getting better. It was getting worse. I checked the heart. There was nothing there. I checked everything else. Eventually, I was like, well, it's really odd. But I think, maybe this person could have bilateral extremity DVTs. And sure enough, he did. And it was, how many times do you see bilateral extremity DVTs? Almost never, right? I mean, it's crazy. But you always have to think about, what is the endpoint diagnosis? Just because you eliminated the main causes doesn't mean you've reached an endpoint diagnosis. And I think this case is a great reflection of that. And you might only have one thing to go off of, and that was the extremity edema, but herein we arrived at ovarian cancer. So wow, what an amazing case. Thank you so much for sharing. And I'd love to hear your reflections, Radha, and taking care of this patient and kind of what you learned and how you guys were so skilled at getting to the final diagnosis.
A few things that I learned is what was already somewhat said, which is, staying humble, keeping your mind open to one of the things that was somewhat of a tip off for us was her outpatient labs and the change in her thrombocytosis, as well as the fact that she was asymptomatic, which prompted us, at least me, to at least try to find lymph nodes. And something I learned afterwards about IBC syndrome is that it can oftentimes present asymptomatically, which was one of my takeaways, because I was wondering how she just had this lower extremity edema and nothing else. So, yeah.
Amazing. Thank you so much for this case and for your reflections. I think we all learned a lot. Thank you so much, Austin, Kiara, and Francisco, for the discussion. And we have like a few minutes, and if anyone has a question about the program and want to ask for Valentina and Rada, we had one question that was like, wanted to know more about the Global Health Track and International Scholars Program, the differences between these two tracks and the traditional category program.
Of course. First of all, thank you guys. That was a very live discussion. Like I was like looking in the chat. I loved how like the input of everybody, plus our discussants online. So this was fantastic. I could not have asked for like a better discussion in case to turn out to be great. In terms of the question, so if you, the person who's asking, if you are an IMG, meaning that you graduated in a non-US medical school, the only way that we actually hire people or like we recruit people being an IMG is through the IST, the International Scholar Track. This is because it's just like 7 slots that are just allocated to IMGs. We actually do a separate interview process for ISTs. So it's just a little bit different. So because of that, for better or for worse, we are not eligible for the Global Health Track being IMGs. So Global Health Track and Women's Health are 2 of the tracks that our residency program has, that if you are an AMG, graduated in an American medical school, you can opt in, and it's a different NRMP number. So whenever you rank us, you have to rank the Global Health Track or the Women's Health separated from the categorical. Now, having said all of that, we have a lot of tracks. We have Global Health, we have Women's Health, we have also we offer Research Pathway, we have International Scholar, we have Clinical Scientist track. So there's like many options. If you are like an AMG, there's like plenty of options for you. Some of them you have to rank in the NRMP separately. Some of the other ones, as soon as you match, you kind of like decide to go into those. I will say that a lot of people ask me, like, being an IST, is it different than a categorical? Our curriculums are exactly the same. We rotate with the categoricals exactly the same amount of months. The only thing that differs is that we have the same, it's like a more intense curriculum in terms of research. We share that track with the clinical scientist people, and it's just, we have a little bit more of like seminars in terms of like how to get going with like research projects. What resources do you need to like complete some research projects? We have also like some time separated on our second year, in the summer of our second year, to do courses at the ICRE if you want to. So just like there's a little bit more focus in terms of your research. But the rest of it is just the exact same with the, like you share the exact same thing with the categoricals. Global Health has probably what Irada mentioned a little bit. It has like those international opportunities. We have some connections with Malawi, some connections in the Philippines, in Manila. We also have like some connections in reserve like Navajo areas in Arizona. So there's like other things like that. That as of right now, I don't think that anybody else that it's a categorical or IST can opt in. It's just like purely for the global health people, just because it requires a little bit more funding.
Thank you so much for your answer. And then there's one more question, like what's the most unique thing about the international track, the scholar track, and what you enjoy most in the program?
I'm gonna start with what is the most unique. I think when I was interviewing, there was not a lot. I think if there was 2 programs out there in the US that had like this particular track for IMGs, there was not more than that. And I will say that I feel extremely grateful, and I feel that my program understands like some of the struggles of being an IMG. They have been having this track for years and years. There's like a dedicated program director just for us, for like the 7 of us per class. And I just feel like it was extremely supportive. Like they didn't ever looked at me like, oh my God, I have to give you a visa, or like it's just like this hassle. They are like, this is what we hire you because we think that this diversity, like the fact that we have 7 of you guys coming from like very different medical schools in like Central America, in Africa, Europe, South America, everywhere, makes our program like richer and more diverse, and that's why we value you. So I felt like so welcome since like day one when I interviewed there. I felt like they wanted me there, and they had like all these resources behind this like international scholar program. So that is, I think, the most unique. What I have enjoyed the most about my program, I would say, is the medical education. This excites me a lot. Like being here with you guys doing this virtual morning report, because this is kind of like one of the things that I do think that in UPMC we value a lot. All of our faculty, most of our faculty have master's degree in medical education. People try to build like curriculums. We try to just kind of like get as much feedback as we can to improve our medical education. So that I think is what I've enjoyed the most of my residency program. I don't know, how about you, Irada? And Tiago is also here. He can also share.
I think I touched on this earlier too, but I really like the people here. Everyone here is great. Residency is not always the most fun experience, but the people here have made it really fun, and I've really enjoyed my time at UPMC, and I'm so glad I'm here.
Yeah, thank you, Tiago. I think like he's also like helping answer some of the questions in terms of like in time of applying. Yeah, unfortunately, like if you're applying in this cycle, it should have happened already. But just so you know, it's just kind of like because it's like different NRMP codes, you should just have to click on that one for people who are like thinking of applying next year.
Yeah, one thing for application overall, don't believe the cutoffs for graduation, because I applied, I was 10 years from my graduation, and a lot of places in the website, they said that they don't accept if you're over 3, 5, whatever, and I had interviews there. So that's my personal perspective and experience. So every time that you see, we have a filter from graduation. We never know. We like as a foreigner, we never know. It's sometimes random. So yeah, but I'm here after 10 years of graduation. So I'm the oldest, but I think if you're 30 years of graduation, they would consider also.
Amazing. Thank you, Tiago, for your advice. And about the city, maybe we can ask how is the city? What do you enjoy most about it?
Yeah, I think like early in the call when we were like hopping on and like talking about Pittsburgh, that has been one of the things. It's very underrated. Okay, coming from, again, like I come from like the second biggest city in Colombia. It's quite like metropolitan. So like as soon as I thought Pittsburgh, I was like, first of all, I have never heard of this city ever. It's on the smaller scale. They consider it like maybe like a middle size. I would say like it's a small to middle. Some of it has like certain feelings of a bigger city, but I would say like pleasantly surprised about the gastronomic offer that they have. So like good restaurants, They also have like great things to do. I really like, again, as I mentioned, like they have plenty of yoga studios, plenty of green spaces. I will say it's also very, very affordable. So if you guys are thinking, obviously, like compared to like bigger cities as Boston and New York, with the salary that you make as a resident, it's very easy to like live, have a car, travel, save some money. If you're living with a roommate or something, even better. So I really enjoyed that part of it. I also will have to be honest, the hardest thing is having a smaller airport. That has been a pain point for me. But other than that, I think, and Tiago's asking what it's underrated. It means that like people like just badmouth the city, or like they think it's not as good as it like actually is when you live there. So that's why I think it's underrated. I don't know, what do you guys think, Irada, and Tiago?
I'm from Michigan, where most times of the year you could go outside and like hurts your face because it's so cold, and it's a lot warmer here. If you're from somewhere that's actually warm, it might not feel that way, but the weather here is actually pretty nice. And as I said, it's November and sunny, and there might be other reasons for that are bigger than us just being in Pittsburgh, but I've been enjoying it here. It's really pretty in terms of nature, but then if you also want like some city vibes, it's out here too. You can kind of get a little bit of everything you want. The only downside I would say is the Pittsburgh roads. That is its own unique challenge that I've had to navigate. So if you're a first-time driver and you're learning to drive here, you will become very good at the end of it all.
Yeah, I did understand what was underrated. So the city, so it depends on what city you like. I'm just checking here. The population in the metro area is 1,700,000. So the Great Pittsburgh is kind of not small, but the city itself, I think it's 300,000 people living here.
Yeah.
Yeah. Yeah. So it depends on what kind of city you like. I came from Brazil straight to residency, so different than Irada, I was not in Michigan, so I think it's cold here in the winter. For the size of the city, this is not like New York for sure. That's very different than New York, but that's not like a small city. So it depends on what kind of city you like. But I'll tell you, my first time in Pittsburgh, I was interviewing. And then I had an interview here. I came here and I loved the city actually. That my first time here was in December. It was winter. I was hosted by Professor Reza Manash. He's from Pittsburgh. And he came to medical school at the University of Pittsburgh as well. So I had a great time with him here December 2021. I like the city. It's clean. But yeah, it depends on the kind of season, the kind of city that you like.
I think there was also another question in the chat. To get accepted into the IST program, is it important to have extensive research background? I will say we are kind of like in the middle. So if you are, for example, an IMG that has been doing like a postdoc for like years and years, you're kind of like more of a basic science bench researcher. Maybe UPMC is not the greatest place for you. We tend to get people who do have like a little bit of a research background, but maybe like more focused on like clinical research, because I think our residency is also looking to train like great clinicians. So we do have some time for research. I'm not saying that's kind of like off the table completely, but we are trying to just kind of like train people a little bit more balanced. So our clinical, the clinical parts of our residency are a little bit heavier than maybe other programs that want for you to be like a researcher. Although I have seen people that have graduated from our program that definitely are like a clinician scientist, just in the making, basically. So there's a little bit of both, but that's kind of how I would maybe frame the research background.
Thank you so much for answering our questions. We are getting to the end of the session. I really appreciate you all for coming. Thank you so much, Tiago, for contacting me and Yas with Valentina. Thank you, Valentina Irada, for being with us today. It was a really pleasure. And yeah, we wish good luck for everyone that is applying, and definitely consider this amazing program.
Thank you, guys. Thank you for having us. This was really fun.
Bye-bye.